Hello, everyone, and thank you for joining us. I am Suzanne LeBlanc, the Director of Clinical Relationships for the Focused Ultrasound Foundation. I interact with members of the scientific community, including preclinical researchers and clinicians, as well as medical societies and nonprofits, in order to form meaningful collaborations. I also help initiate translational projects. Before we get started, a few technical items. If your connection is lost, please simply log in again through the link you received when you registered. Once the live viewing has concluded, you will receive a link to a recording of the webinar as well. If you'd like to ask a question, please submit it at any time via the Q&A function at the bottom of your screen. We will collect these questions and answer as many as possible during the audience Q&A portion of our discussion. And now to our speaker. Today we are joined by Dr. Stephen Bagley, Assistant Professor in the Division of Hematology Oncology at the University of Pennsylvania Perelman School of Medicine and a board-certified medical oncologist. His primary area of research and clinical interest is in neuro-oncology. After completing medical school, residency, and fellowship at Penn, Dr. Bagley completed a formal clinical research training program to obtain a Master of Science in Clinical Epidemiology, with a formal concentration in the design and analysis of clinical trials. His current clinical and translational research focus is the development of early phase, investigator-initiated clinical trials for glioblastoma, as well as novel methods for integrating liquid biopsy into the care of patients with brain tumors. He is the principal investigator of multiple currently enrolling brain tumor trials at Penn and leads Penn's research efforts to develop liquid biopsy patients with glioblastoma. Today, Dr. Bagley will present an overview of the potential of liquid biopsy in patients with brain tumors. We are also fortunate for the Q&A session will be moderated by Dr. Achal Atrol, a neurosurgeon specializing in minimally invasive keyhole neurosurgery for brain tumors. He currently serves as Director of the Glioma Program and Director of Brain Tumor Translational Research at Loma Linda University in California. He received his BS in Computer Science and Electrical Engineering from George Washington University and his MD from Stanford University, where he also completed his neurosurgical training. In addition to his clinical roles, Dr. Atrol is leading industry efforts in developing non-invasive, incisionless neurosurgery using transcranial MR-guided focused ultrasound, serving also as VP Global Head of Medical Affairs at Insightec. For now, Dr. Bagley, the floor is yours.
Thank you very much, Susie, for the kind introduction. And it's a real pleasure and honor to be here today to give this talk entitled Liquid Biopsy for Brain Tumors, Recent Advances and Future Directions. These are my disclosures. So for those of you who are not familiar with glioblastoma, this is the most common malignant primary brain tumor in adults, and unfortunately is near uniformly fatal. And one of the main reasons is that there really is no early stage disease. On the right side of the screen there, you'll see what this tumor looks like grossly, both on gross pathology as well as MRI scan. And on the right is actually a whole brain slice from an autopsy study. And the little black dots represent areas of tumor that were seen only microscopically. So you get the sense that even though we can see a gross tumor, there's much more underneath the surface. And this really is a disease of the entire brain. And because of this, the median overall survival remains quite poor, only 12 to 14 months in the real world, with a 5-year survival rate that's quite dismal, around 5 to 10%. This is one of the few remaining cancers without any new systemic therapy approved by the FDA within the past decade. The last approval came in 2009 with a drug called bevacizumab. And any of you who have ever taken care of or known a patient with this disease recognizes the tremendous loss of function, cognition, and personality that occurs, and the burden that this places on their caregivers. And for all of these reasons and many others, this is a disease that represents a major unmet medical need on many levels. Just to walk you through the typical course of a patient with this disease, the first step is to do a maximal safe resection of the tumor. So the patient goes to the operating room, and typically that tumor is sent for some sort of genetic sequencing, and we'll get into this in a little bit, to try to understand what markers may be present in the tumor to predict response to therapy, and potentially to find therapeutic targets. After surgery, the patient goes on to get radiation, along with an alkylating chemotherapy drug called temozolomide. At some point, we see the MRI start to look worse. And we don't know, a lot of the time, whether those changes represent progressive tumor or not. And we're often set in a situation where we're looking at offering the patient ineffective standard therapies, things like bevacizumab, which I mentioned previously, looking for a clinical trial, which requires molecular data much of the time, or off-label systemic therapy, again, where this molecular data we obtain from the tumor at the beginning of treatment may actually be helpful. They often will go back for a second surgery. And again, we're taking that tumor that's now recurred and sending it off for sequencing. There are a lot of problems that many of you have already probably noticed in the first few seconds here with how this works. One of them is that we actually still have no idea which patients are going to do very well with the standard of care and which ones are going to blow right through it. There are certain prognostic markers that have shown up over the years, things like age, performance status. There's a test called MGMT methylation that we do on these tumors. None of these are perfect. So that's a real challenge when you're having a goals of care conversation at the beginning of treatment with these patients. The second problem is that we're very uncertain in most patients of when the tumor is progressing. The changes I showed you on this particular MRI are very characteristic, and they can look exactly the same whether you're dealing with a progressive tumor or if you're dealing with inflammation and disruption of the blood-brain barrier by the radiation. Both of those things lead to increased contrast enhancement and can look identical on an MRI. So we're often stuck there. And other problems at the time of recurrence include, number one, the molecular profile can be quite different at the time of recurrence. So to understand that, you often have to take the patient back for a biopsy or a repeat craniotomy at the time of recurrence. And I don't have to tell anyone here who's either done brain surgery themselves or who's undergone it, this is a big deal. This is not the same thing as putting a needle into a lymph node or something like that. So with all of these problems that we face in clinical practice, I want to really focus today on how liquid biopsy, even though it's in its early stages for this disease, may one day solve or at least improve our ability to deal with some of these problems. So liquid biopsy very broadly refers to trying to obtain tumor genetic material from any bodily fluid compartment. Most often this is done in the blood, and that's what we're going to focus on today. But spinal fluid, saliva, pleural fluid, these are all options as well. Whatever fluid is selected, the tumor will shed various elements into that compartment that can then be used for genetic testing. These might include circulating tumor cells in the bloodstream, exosomes that are secreted from tumor cells, or DNA that's floating freely in the bloodstream, referred to as cell-free DNA. That's really going to be the focus of today's talk, mainly because that is really what's furthest along in clinical development. So by way of overview, I'm going to start with an introduction to liquid biopsy and circulating tumor material in oncology in general, and show you what's been done across a number of tumor types thus far. Then we'll talk about applications of liquid biopsy and circulating tumor material specifically to brain tumors. And then we'll end by going over some of the ongoing research at our institution and what's going on more broadly, and including, of course, focused ultrasound. So there are many potential uses for liquid biopsy in cancer. One is for individualized prognostication. Another is for tumor genetic sequencing, assessment of response and resistance to therapy, and even potentially earlier detection of cancer, and maybe one day routine screening. The key is that all of these can be done non-invasively, or at least in some cases like cerebral spinal fluid, still invasive, but less so than tumor tissue acquisition. These opportunities have not been lost on industry, and as a result, there are actually 4 liquid biopsy assays that have been approved by the FDA so far for certain cancers. And there are many more that are in commercial development, and some of these have been given FDA breakthrough designation. So it's very likely that we're going to see a large increase in the number of commercially available assays in the coming years. A brief word of nomenclature. So plasma cell-free DNA, or cfDNA, which I'll refer to for the rest of the talk, refers to a background level of cell-free DNA that exists even in healthy patients. A much smaller proportion of this in cancer patients is ctDNA, or circulating tumor-derived DNA. Both of these have a very short half-life, existing in the circulation for only 15 minutes to a couple of hours. And because of this, you have the opportunity to capture real-time tumor homeostasis. So first of all, I want to focus on what's been done in looking at ctDNA as a prognostic or predictive biomarker in solid tumors. This was a nice study that was done by Stover and colleagues in triple-negative breast cancer. It's very simple analysis where you're just looking at what fraction of the cfDNA pool is tumor-derived. If it's greater than 10%, you can do those patients do much worse in terms of their overall survival compared to patients who have a tumor fraction of less than 10% who do much better. Even in earlier stage cancers, like here, inoperable gastric cancer, these are patients who are actually going for a curative intent surgery. And before that surgery, if you can detect a variant from the tumor in the bloodstream, your predicted survival time is much worse compared to patients where ctDNA variants were not detected. The other way that ctDNA is being used in clinical practice across a number of tumors is to get a more comprehensive view of the tumor genome. You can imagine that if you're looking at tumor DNA that's been shed from the bloodstream, you may actually be able to look at a number of different means of sequencing that DNA. You can look for translocations, insertions, deletions, point mutations, chromosomal aberrations, epigenetic marks, and even amplifications, copy number gain. The key is that liquid biopsy can actually detect tumor that's being shed from multiple sites of disease. So you can picture this patient who may have lung metastases, liver metastases, and a primary pancreas tumor. If you were to biopsy one of those sites, you're only going to get the mutations present in that one site. But we know that even within an individual tumor site, neighboring tumor cells can actually harbor different genetic profiles and therefore can have differing responsiveness to certain drugs. So taking a liquid biopsy and getting a sense of the entire cancer genome may enable a better assessment of this, what we call tumor heterogeneity, and allow you to detect subclonal mutations that may eventually lead to treatment resistance. So a natural question is, if you do this, how well does it actually recapitulate what you'll see if you sequence the tumor? So this varies depending on what assay you use, and it varies depending on the tumor that's being talked about. One nice example here was a study of whole exome sequencing in the blood of breast and prostate cancer patients. What I want to draw your attention to is the graph on the left. Each one of those columns is an individual patient, and the y-axis shows you the percent of mutations that were shared, meaning they were found in both tumor sequencing and in matched blood. The mutations by these investigators that were termed clonal, meaning that greater than or equal to 90% of the total tumor-derived DNA had that mutation, those were highly conserved and very much concordant between tumor and cfDNA, with an average of about 0.88 concordance rate. On the right side, you'll see the yellow bars. These were subclonal mutations. And these subclonal mutations, the concordance is much poorer. And this is actually, on the one hand, disappointing because you may draw a liquid biopsy in these patients and you're actually not getting the same information you would get from a tumor biopsy. But on the other hand, is actually very important because you may pick up mutations that you wouldn't have seen had you sequenced the tumor. And those particular mutations may be the ones that are key to target or that may enable resistance of the tumor to treatment. So looking at this specifically in lung cancer, this was a study that was done at our institution. These are non-small cell lung cancer patients, and each column represents a different patient. And on the left side, you'll see the different mutations that were found. The color coding refers to whether the mutation was detected only in the blood, which is the red boxes, if it was detected in both blood and tissue, which are the yellow boxes, or maybe only in the tumor, which are the blue boxes. What I want to draw your attention to are these first 6 patients here, where you can see the red boxes for something called EGFR T790M. This is a key resistance mutation in EGFR mutant non-small cell lung cancer, and we actually have drugs for this mutation. So these patients in this particular study had this mutation found only in the blood and not in paired tissue that was sequenced. And these patients all responded to that drug when treated in the clinic. Similar results have been seen in metastatic gastrointestinal cancers. So this was a study looking at tumor biopsies on the bottom and then ctDNA biopsies on the top in patients with metastatic GI cancer. And the key here is that in the ctDNA group, you pick up a whole lot more of these resistance alterations in the blood than you do if you look only in the tumor. So this is now starting to impact clinical practice both in lung cancer and in a number of GI tumors. A logical follow-up to this may be, well, if we can detect these mutations in the blood, can we track them over time to get a better understanding of how the patient is responding or perhaps becoming resistant to targeted therapies? You can imagine that if the tumor size is decreasing, you may see a decreased quantity of a particular mutation in the blood over time, whereas if the tumor size is increasing and the disease is progressing, you may see an increased quantity of the identified mutation over time. Sure enough, this has been seen in a number of tumors. I'm going to show you an example just from BRAF V600E mutant melanoma. So this is a tumor where we have very effective targeted therapies against this particular mutation. And what they did in this nice study by Corcoran and colleagues was they looked at a number of patients over time who were receiving targeted therapies against this mutation. On the y-axis is the mutant allele fraction of BRAF V600E in the blood. And these three groups are broken down by patients with complete or partial response on the left, stable disease in the middle, or progressive disease on the right. The patients who had a complete or partial response actually had uniform drops in their mutant allele fraction over time, followed by an uptick at the time of disease progression. Patients with stable disease also tended to have drops, whereas patients with progressive disease were kind of all over the place. So this is something that is still being worked out in a number of other tumor types, but represents one way that we may be able to non-invasively monitor response to disease without having to rely on radiographic imaging. People have also wondered if a similar approach can be used to predict response to immunotherapy. So this was another study from our institution where we looked at plasma tumor mutational burden, or TMB, to predict response to immunotherapy in advanced non-small cell lung cancer. So many of you may know that the tumor mutational burden has been shown over and over again to predict response to immunotherapy across a number of tumor types. But this study actually looked at doing this in the blood rather than in the tumor. This shows you patients with first-line treatment, either pembrolizumab monotherapy or pembrolizumab plus chemotherapy for advanced non-small cell lung cancer. And you can see that both for progression-free survival on the top and overall survival on the bottom, survival is a lot better in patients who had TMB high as detected in the plasma. This particular study was done using a panel from a company called Garden Health, but there are a variety of other ways that this could be done in the bloodstream, and all of these are being investigated both in lung cancer and in melanoma. So despite all of these exciting results I've showed you, and the fact that this really has started to enter the clinic in a variety of tumor types, there are some major controversies and I think a lot of problems that still need to be worked out. One of the biggest problems is that there are a lot of factors that influence the sensitivity of liquid biopsy for detecting tumor mutations, and it's not so simple as just looking at the tumor burden. I think in early days of this, people thought that patients with very extensive metastatic disease may have a much higher likelihood of having mutations detected, and that really has not been the case. That's one small factor in which tumors shed DNA into the circulation. Other things are shown in this nice review from Heitzer and colleagues in Nature Review Genetics last year. The other factors that are important are the sampling volume, of course, depending on how much plasma you can obtain from the patient, but also the number of input molecules. So how efficiently can you actually extract DNA from that sample? And then on the right here, every single assay you would use, whether it's a commercially available panel or something in-house, they all have their own analytical limit of detection. And if you're looking at something on the right side of this diagram that has very high analytical sensitivity, for example, something like droplet digital PCR for a specific mutation, your sensitivity is going to be very high. Conversely, if you look at something like whole exome sequencing or whole genome sequencing, where you've got a lot more genomic coverage, the sensitivity in that scenario tends to be a lot lower because you require so much more DNA. The tumor fraction is also really important. As I showed you earlier, certain patients secrete a lot more DNA from their tumors compared to others. So if the tumor fraction is very low, which it often is in glioblastoma, as we're going to get into, it can be a lot harder to find mutations. Other factors are that it can be hard to tell the difference between somatic tumor mutations in the blood and clonal hematopoiesis. And this is, just where our white blood cells over time as we age can accumulate mutations that are clonal. And because white blood cells, really make up the bulk of the sample that's being obtained in these liquid biopsies, you can pick up these mutations, and many of them are the same things you would expect to see in a tumor. So that can be very tricky. Every company who does this has really developed their own bioinformatic pipelines to try to sift through these and call them one way or the other, tumor derived or not, but it's not always so straightforward. And then lastly, many available ctDNA sequencing assays actually lack clinical validity despite being used in the clinic. There are a number of studies now. One of the most, I think, provocative was a study by Stetson and colleagues in JCO Precision Oncology last year, where they actually looked at a number of commercially available assays and compared them. And they were finding completely different results when they sequenced the same samples from the same patients on different platforms. So this raised some red flags in the field, and I think everyone sort of is taking a step back and saying, we need to make sure we really understand the operating characteristics of these assays before they're being used so routinely. And a lot of that has to do with background noise that needs to be sifted through, again, through these complex bioinformatic pipelines. So I now want to move on from this general overview into specific applications of liquid biopsy and circulating tumor material to primary brain tumors, where this has been a real challenge. So the appeal of using this technology in patients with glioblastoma, I hope, is obvious at this point. For one thing, blood draws or even a spinal tap is considerably less invasive than brain surgery. Secondly, glioblastoma, one of its hallmarks is extreme and very difficult to treat tumor heterogeneity. And what I mean by that is shown nicely in this diagram here. Even in one patient, in one tumor, if you actually do single cell sequencing on that tumor, you'll find that neighboring individual cancer cells may have different mutations, they may have different transcriptional profiles. And so this becomes sort of a mind-boggling challenge when you're thinking about how to apply targeted therapy to this disease. And then third, I showed you earlier that MRI scan is limited in its ability to monitor response and progression on therapy. So see, these are just some of the areas where liquid biopsy is starting to be applied and researched for glioblastoma. So I first want to start by showing you kind of the early days of this. In 2014, Chetan Bedagowda and colleagues published a landmark paper in Science Translational Medicine. This was looking across a number of different tumors. You can see here on the x-axis a number of them, and just trying to find ctDNA in the blood of these patients and sequence it. You'll find that certain tumors here, if you take a look on the left, bladder, colorectal, certain GI cancers, ovarian, had very high rates of somatic mutation detection. All the way down here in the end sits glioma, 27 patients, very, very low rate of detectable ctDNA. This really, I think, put a damper on things. Everyone saw this data and people were pretty discouraged about pursuing this for brain tumors, and I think rightfully so. It's still worth pointing out that there are a couple of limitations here that have to be pointed out. One is that of those 27 patients with glioma, only 13, actually 13 of them had low-grade gliomas, meaning only 14 had higher grade gliomas. And we know that the blood-brain barrier is very important for how much of this actually makes it into the circulation. So you can imagine a low-grade glioma with an intact blood-brain barrier may have a much lower likelihood of shedding DNA into the circulation. And then also these patients had plasma detected, obtained at different points in their disease course. So somebody who's got very large progressing tumor burden may have a different amount of tumor DNA in the circulation compared to somebody who's finished treatment and is not progressing at all. So these are important details that I think need to be looked into further. The one quick word on this with the blood-brain barrier, all of these tumors, to some extent, have areas where the blood-brain barrier is broken down. And we know that because when you inject gadolinium into the bloodstream for an MRI, you can see it extravasate into the brain in certain areas. But that's only the tip of the iceberg. There are other parts of these tumors, even in grade 4 glioblastomas, that have a very much intact blood-brain barrier. And it's both delivering drugs to those part of the brain, that's a big challenge, but also trying to obtain tumor material, like through liquid biopsy, from these areas with an intact blood-brain barrier. So some of the other things that have been done since that initial study, I want to walk through quickly. One important study looked at diffuse midline glioma patients. This is a special type of high-grade glioma that's characterized by a mutation in histone 3 called the H3K27M mutation. In children, this disease is known as DIPG, or diffuse intrinsic pontine glioma. Because we know exactly what mutation this is, droplet digital PCR assays have been designed, And this gets back to what I was saying earlier. If you know what you're looking for, you can use a very highly sensitive assay like this to find the mutation in the blood. Sure enough, this is what was seen in this study published in Clinical Cancer Research a couple years ago. These are kids with DIPG, and you'll see each column on this graph represents a different patient, and the orange bars are the mutant allele fraction of this mutation detected in the plasma of these patients. Almost all of them had detectable plasma at baseline. There were only a few that didn't, and they actually turned out, the ones with the asterisks, turned out to be histone 3 wild-type tumors, so you wouldn't expect them to have the mutation. And of these few where it wasn't detected, they actually looked again after completing radiation. That's on the right here. And now you start to find it. So depending on when you look during the course of treatment, the yield actually goes up. So I think this is an important proof of principle that if you know what mutation you want to sequence, the yield in the blood actually goes up a fair amount. This is a similar study. This is actually an older study published in 2012 looking at IDH mutant gliomas. And the key I want to point out here in this table is that in the low-grade glioma patients, which is the top half of the table, the rate of detection of IDH1 R132H mutation in the blood was quite low. But in the high-grade patients, they actually found it in 70% of the patients in the bloodstream, again suggesting that blood-brain barrier permeability may have something to do with the yield of ctDNA in these patients. What about using commercially available patients, commercially available assays for glioblastoma patients? So this was a paper published by David Piccioni and colleagues from UCSD last year in CNS Oncology. They did a very simple analysis, which was to look at all of the primary central nervous system tumors that have been sequenced at Guardant Health, which is one of the commercial entities doing this. So these were tumors that doctors just sent to the company hoping to find something. And there were 419 of them. In the glioblastoma group here with the arrow, there were 222 patients, and 55% of them had something detected on the panel. So at least one alteration that came up as positive. And this is the list of all of those mutations, and you know, on the x-axis here is the number of alterations in each of these genes that was detected. You can see for TP53, there were a whole lot of them, but as you go down the list of all the others, the numbers start to go down considerably. I put arrows next to the ones that may have potential therapeutic relevance. So I think this study gained a lot of attention, and I think it was interesting and hypothesis generating. But one of the major drawbacks is that there were no matched tissue specimens here. And so we don't know, you know, what is the concordance with tissue in this disease? How many of these mutations are actually tumor derived versus clonal hematopoiesis, which I showed you before? And how many of them are just assay noise that's picked up because every single test we do has some background level of noise to it. So these are questions that we started to think about. And I'll show you some of the work we've done so far in a few minutes. Cerebral spinal fluid is the other area for brain tumors that's being looked at very closely. And the reason is that there's much more intimate contact with the brain, you know, between CSF and these tumors. And we know now that the concentration of ctDNA in CSF is about 10-fold greater than it would be in plasma. And this is mainly because CSF in a quiescent state is paucicellular and really possesses a low background level of cell-free DNA. So that noise problem really goes away in the CSF. One of the early looks at this for brain tumor patients came from Martinez Riccardi and colleagues a couple years ago in Clinical Cancer Research. In this study, each patient, again, is across the top here as a column. For the IDH mutant tumors, they took a look at tumor, and right below that, matched CSF. And in the patients here on the right side, who were all these different IDH mutant type of tumors, concordance was actually pretty good, as you can see here. And then over here, patients 1 through 9, these are the run-of-the-mill glioblastoma patients who do not have IDH mutations. And there they looked specifically at TERT promoter mutations. And again, very high concordance rate. You find the TERT promoter mutation both in tumor and CSF in most patients. So this was, I think, a good proof of principle that CSF may have better concordance and better yield of ctDNA compared to plasma. This was followed more recently by, I would call, a landmark publication in Nature from Memorial Sloan Kettering last year. Miller and colleagues looked at 85 patients with brain tumors at Memorial Sloan Kettering, and they had patients at various points in their time course have CSF collected and then sequenced for ctDNA. And they found at least one mutation in the CSF of about half of the patients. And this important figure from the paper here shows you that most of the mutations were concordant but some are actually private to one compartment. So if you look at patient 5 here all the way in the left, they've got a lot of mutations that were found only in CSF and not in matched tissue. And as you go down the line here, you can see that the proportion that were shared versus private varies a lot from patient to patient. One important thing that came out of this paper also is that the tumor molecular evolution, which changes over time. As I showed you at the very beginning, there may be resistance mutations that emerge down the line that were not present when the tumor was initially sequenced at the time of the first diagnosis. So this was one patient in their study. The diamond here represents the very beginning of their treatment at their initial craniotomy. And the circle here, 18 months later, is their CSF draw at the time of tumor recurrence. And what you'll see in this figure are the mutations detected in those 2 samples. So in the tissue at the beginning, you've got TERT promoter, PTEN, CSF1R. And at the time of CSF collection at recurrence, you've actually lost some of these mutations. For example, EGFR is gone. Now you've got PDGFRA, and actually the copy numbers here have changed as well. So EGFR was amplified at the beginning, no longer at recurrence. And the tumor in the CSF sequencing at recurrence had actually gained some amplification of a number of other genes. So these are completely different molecular profiles. And you can see how this patient, their treatment may have changed based on a CSF draw, and did not require another craniotomy at that time point. So I think really interesting results that really warrant larger sample sizes and more multi-center studies to take a look at how this may impact practice. So those overviews of liquid biopsy, both in other tumors and in primary brain tumors, I think have sort of set the stage for the final part of the talk, where I want to focus on what we've been doing at Penn to try to understand this a little bit better and talk about some future research directions and of course, including focused ultrasound. So we published a paper earlier this year in Clinical Cancer Research, looking at the clinical utility of plasma cell-free DNA in adults with newly diagnosed glioblastoma. And this was really a pilot prospective study where we really just wanted to kind of start from scratch and understand some of the basic operating characteristics of cfDNA in these patients and how we can start to understand potential clinical utility. This was not a definitive study, rather an initial pilot approach. So what we did was we started banking plasma on our glioblastoma patients at Penn, and we actually started taking it prior to their initial surgery for GBM. So we're screening patients who have a suspected high-grade glioma based on, coming into the emergency room with a headache and having an MRI that's concerning. And I think one important part of this study was that we drew that blood at a time of high tumor burden prior to initial craniotomy. And then the patients went on over time during the course of their routine treatment to get blood draws throughout the course of their therapy. They had a blood draw at their postoperative MRI, again, before and after standard radiation and temozolomide, at their first post-radiation MRI scan, and then again, every 8 weeks for the duration of their disease course, matched with their standard of care MRI scans every 8 weeks. So the main objectives of the study were, number one, to try to determine whether there's any prognostic impact of baseline and post-treatment plasma cfDNA levels in these patients, and then to also try to obtain a preliminary estimate of the concordance between tumor somatic variants detected in plasma and in matched tumor from these newly diagnosed patients. So to do this, very briefly, for the cfDNA extraction and quantification, we just drew whole blood samples in Streck cfDNA tubes, which are preservative tubes that allow you to let that sit for a few days. So it doesn't have to be rushed to a lab and spun down immediately. And then we measure the raw plasma cfDNA concentration in nanograms per ml, quantified by qPCR, and we do this for a 115 base pair amplicon of the human allorepeat element. So this is a very standard way of simply measuring how much raw cfDNA there is in the circulation. This is not designed to try to figure out how much of it's tumor derived, and we're not looking particularly for mutations in this type of analysis. We really just want that raw quantity of cfDNA, and we'll get back to that in a few minutes. For the sequencing part of this, the plasma was done by Garden 360, which is a commercial available 73 gene targeted panel for plasma that has very extensive prior analytical and clinical validity, a number of publications listed here. And then we used our in-house tumor next generation sequencing panel at the Penn Center for Personalized Diagnostics for the tissue. This is a 153 gene solid tumor panel. These were done at matched time points. So first, we just took a look at the cfDNA concentrations in our GBM patients and compared them to age-matched healthy controls. You can see on the right, these are the GBM patients. They on average have a much higher cfDNA concentration, with some of the patients having markedly elevated concentrations. There's a couple outliers here in the healthy population who actually, unfortunately, may not have been healthy and didn't know it yet, but we don't know that. But you can see that the stark contrast between diseased patients and healthy patients. Then we just took a really simple look here and we broke it down according to the mean level. So patients with GBM who had low plasma cfDNA defined as below the mean value, and those with high plasma cfDNA defined as above the mean value. And we saw, a striking difference in progression-free survival, and then somewhat of a trend toward a difference in overall survival. So we thought, well, this is kind of interesting and hadn't been shown before. So as we continued to collect more patients, we took a more sort of scientific, an objective look at this. And what we did was try to develop an optimal cutoff value for plasma cfDNA. And we had to decide about a landmark time point to look at in order to do this type of analysis. So we said, why don't we just look at the median progression-free survival for newly diagnosed glioblastoma patients, which is 7 months, according to this landmark study from Stoop and colleagues with radiation and temozolomide. And let's see if cfDNA can predict which patients are going to be, beyond that time point when they progress, and which patients are going to progress prior to that median expected PFS time of 7 months. And I'll refer to that moving forward as PFS 7. So this is data that we just presented at ASCO this year. And so the discovery cohort came from that same clinical cancer research cohort I just showed you. And we just did a very simple ROC analysis here. And for predicting PFS 7, we found an optimal cutoff value of 22.7 nanograms per ml with an AUC of 0.72, which by itself, for those of you who are familiar with this kind of work, is not a great test. It's decent, but it's not the kind of thing where you'd be moving this to clinical practice immediately. You're usually looking for AUCs of 0.9 or higher for that kind of test. But it was intriguing. And what we did next was broke the group down according to this cutoff, and you can see the stark difference in median progression-free survival between the high and low cfDNA groups. And of course, we had to adjust for other known prognostic factors in this disease to make sure this was an independent and effect. And we did that. And after adjusting for the MGMT methylation status, which is one of our key biomarkers in this disease, how much of the tumor was removed, patient's age, and their performance status, after adjusting for all of these things, the high cfDNA remains independently and strongly associated with PFS 7. So this was interesting. And we, of course, had to show that this remained in a separate test cohort. So that's what we did next. And we took 61 new patients who were not a part of that original cohort and broke them down according to that cutoff value. And for progression-free survival, you can see the difference of 7.3 versus 4.4 months, which was not quite statistically significant, but trending towards it. Same thing with overall survival, 13.4 versus 12 months. This is with a relatively limited follow-up time. This data is really still maturing. So we did the same thing and adjusted for the other known prognostic factors, same ones as before. And for PFS 7, you see that the high cfDNA remains independently associated with worse PFS 7. And for overall survival, using a Cox regression model, the high cfDNA, again, is independently associated with worse overall survival after adjusting for these other factors. So we thought next, well, what if we use this in combination with MGMT, which, as I mentioned a couple of times so far, is really the one biomarker we use in clinical practice already for these patients. And just a quick word on this, this test, MGMT methylation status, the reason this is important is because MGMT is a DNA repair gene that is responsible for repairing damage induced by alkylating agents like temozolomide, which is the chemotherapy we use for this disease. So when MGMT has a methylated promoter, you actually get silencing of the gene and therefore increased sensitivity to these drugs like temozolomide. So in general, as shown in this landmark paper from Heggie and colleagues in the New England Journal of Medicine, if you break patients down according to their methylation status, these are the 4 groups here, the very best patients are the ones who have methylated tumors and who get radiation plus temozolomide. Patients who do the worst are the ones with unmethylated tumors who get radiation alone. But you can see that the curve right above that is patients who are unmethylated and you add the chemotherapy to the radiation, the difference is tiny. This MGMT test is very important, and most of us who take care of patients with glioblastoma, we're getting this on all of our patients to help inform prognosis and to help predict response to temozolomide. So when we combined this with cfDNA, which we did in an exploratory post hoc analysis of all 102 patients enrolled so far, this is what we saw. For progression-free survival time, the group that did well were the patients who were MGMT methylated and had low cfDNA. Everyone else, even if they were methylated, did similarly poorly, with a median progression-free survival hovering around only 4 or 5 months. So it may be that some of the patients who we think are going to do well with a promoter that's methylated, if we actually start testing their cfDNA and seeing that it's high, we may be able to lump them into this worst group from the very beginning and maybe alter their therapy accordingly. This is the overall survival curve. You start to see the same sort of splaying out that follows a pattern very similar to progression-free survival. One other important exploratory analysis I wanted to show you from this data is that everything I've showed you so far is baseline cfDNA. So we're just looking at the pre-operative time point. We thought, well, if that has some prognostic value, maybe we should look at another blood draw after radiation. Maybe patients who are responding really well are going to have very low cfDNA and do great, whereas patients whose tumors are starting to grow again will have high cfDNA and do poorly. So this data is very much still early and maturing, but what we saw so far was in 24 patients, we took cfDNA concentration at the first post-radiation MRI time point, and we wanted to use that to predict their overall survival status at 12 months. So is the patient alive or deceased at 12 months from diagnosis? And when you do this, you get a much stronger predictive value. So the AUC here is very high, 0.87, with a similar but not quite identical cutoff value as before. And the median overall survival time is very different here for these two groups. Again, small numbers, still maturing, but I think very interesting. And when you adjust for the other factors as before, it remains statistically significant. So this is something we're continuing to look at as the number of patients accrued increases, and we hope to collaborate with a number of centers to look at this in a multi-center fashion. And then with regard to the concordance between tumor and plasma sequencing in this study, we only did 20 patients where we did matched plasma sequencing and tumor tissue sequencing. And this is a little bit of a complicated figure, but I think it's pretty, there's one key point from it, which is, the concordance was not good. We did not see many mutations really that overlapped. Each one of these columns here is a different patient, and then all the mutations found are on the left. The blue ones are the ones that are found only in the tumor. The red ones were found only in plasma. And these green ones show, actually they were different variants of the same gene detected by both platforms. But you really don't see concordance here at all. And so this was, as I mentioned earlier, sort of disappointing on the one hand, because it would be great if we could draw blood in these patients and get some sense of what's happening in the tumor. So that's disappointing. But on the other hand, we started to wonder, well, what if we do both? What if we sequence the tissue and the plasma? Are we actually going to gain additional information about the tumor's heterogeneity by doing that? And so that's the question that we're really interested in pursuing now. And I'm going to show you a study that's currently ongoing trying to answer that. And then the last thing is we looked at survival outcomes just according to whether or not any mutations were detected in plasma on that Guardant 360 panel. Patients with at least one somatic mutation detected on the panel did worse in terms of PFS and OS. So this suggests to us that probably at least some of these mutations we're finding are real, probably not all of them, but some of them. Otherwise, it's hard to explain why the patients may be doing worse. So this is, again, subject to larger numbers and more multi-center validation. So I'll end by going through some current and future research directions here. We're looking at this in a multi-center fashion, as I mentioned. We really want to understand the mechanism of high cfDNA and poor outcomes. So why is this high cfDNA seem to be capturing a more aggressive population of patients? So we're doing some methylation profiling of these samples to determine where this is coming from. Is there a particular type of white blood cell where it's coming from? And then lastly, we really want to kind of look at how we can optimize sequencing of these samples, because that's really where I think the money is. And CSF is an important part of this. And we're going to have to figure out a way to get these patients more lumbar punctures. It's not something we typically do in routine practice, but I think will be really important. We need to exclude clonal hematopoiesis better and make sure we're not calling false positives. And then, of course, I'm saving this for last because I had to keep your attention the whole time. Focused ultrasound for opening the blood-brain barrier. And there may be some other techniques that we can use to increase the yield. So for the sake of time, I'm not going to go into this figure in detail, but this is, again, a review I referenced earlier. The point of this figure is just that most of the non-tumor derived DNA that's found in the bloodstream actually comes from white blood cells. And this red mark here, these red bars here are neutrophils. That's really where the predominance comes from. So there actually may be some interplay here where patients with GBM and high cfDNA, there may be some immune mechanism here. And that's something that we really want to look at further. And so we're incorporating cfDNA into our immunotherapy studies as a correlative biomarker for glioblastoma. And then the blood-brain barrier probably plays a really important role here. This was some follow-up work that was done by Ali Nabavizadeh from our institution after our initial paper. We looked at the same cohort and just really dove into their MRI scans to understand, threshold for blood-brain barrier permeability. We happened to choose this one called KEP. I won't go into how exactly we measure that, but it's a surrogate for blood-brain barrier permeability. You can see that as that gets higher, the quantity of cfDNA tends to get higher. And then we also found that the macrophage density in these patients' tumors on histopathology was also correlated with cfDNA concentration, again, suggesting perhaps some immune-mediated mechanism here. And so we're starting to tease this out in additional studies as well. So focused ultrasound with microbubbles may be one way that we can start to actually get better yield in the plasma for these patients with brain tumors. And most of you on this call are probably more familiar with this than I am, but very briefly, focused ultrasound is, really just applying focused energy to this area. And with the oscillating microbubbles that are injected, you get enough pressure that you can start to open up some of these tight junctions. And the diagram here shows drugs that are, sort of diffusing across that blood-brain barrier, but you can imagine it goes the other way as well. So if their tumor is shedding DNA, that may actually make it into the bloodstream more effectively under the influence of focused ultrasound. So this is, just a couple of the ways it can be done. Many of you are probably familiar with the external frame that can be used. This is the Insightec machine, but it can also be done through an implant, as Carpentier and colleagues did in their Science Translational Medicine paper. And this is just showing you an MRI pre and post focused ultrasound. You can really see the increase in contrast enhancement with gadolinium here that you get after focused ultrasound. So, Near Lipsman and colleagues have done a lot of this work. Focused ultrasound is safe. It's been shown to be safe across a number of different diseases. And looking at liquid biopsy, there's an emerging literature, mostly preclinical at this point, looking at this. And this was a study using a mouse glioma model. You can see that they built this apparatus to use this in mice. And these are pre and post FUS. You can see the brisk increase in contrast enhancement. And then they also just looked at, the mRNA levels of a reporter gene that they put into the tumors. And you can see that they go up dramatically after focused ultrasound. And then, more recently, the same group looked at healthy pigs, and they did this in healthy pigs. You can see the contrast enhancement in the area where focused ultrasound was applied. And then these are just looking at some actual proteins that are found in normal healthy brain tissue, GFAP and MBP. Both increased dramatically in the bloodstream after applying the focused ultrasound to these animals. So these have really set the stage, I think, for introducing this into human studies, which is currently ongoing. This is one study we're doing at Penn right now in collaboration with a company called Tempus. We're taking patients with recurrent GBM who are going back to the OR for a clinically indicated surgery. We're actually going to be collecting multiple regions of tumor along with CSF and plasma with a matched Buffy coat. And all of this is going to be sequenced at exactly the same time to try to get a real sense of concordance here, and then see how these may influence treatment decisions. So this is something that I hope to be able to share in the not too distant future. So summary and take home points. I think first, liquid biopsy is really in early days for CNS tumors, but I think holds promise. And there are a number of areas where this may work out. I think one is for non-invasive real-time monitoring of genetics over time and clonal evolution. I think at least so far, CSF is more promising there than plasma, but we'll see what happens with focused ultrasound and other techniques. I think I've already shown you pretty convincing data that we may be able to get a better sense of prognostication using this technology. then potentially maybe a better marker of tumor progression in response to therapy compared to our standard MRIs, which are not great. Liquid biopsy is likely to be most useful in combination with other diagnostic modalities. I don't think we're ever going to be doing just liquid biopsies, probably looking at CSF or plasma sequencing in combination with tissue. And then cfDNA, perhaps in combination with FUS or other novel brain imaging techniques to improve the yield. And then lastly, I really think we need to start working as a community to do larger multi-center studies to better understand really, what we're doing here. I think there are a lot of unanswered questions, and bigger numbers are really the key. And for a rare tumor like glioblastoma, it's got to be multi-center collaboration. So I'll end there. I really want to thank all of our patients and caregivers who participated in this research. Our group at Penn, both in the research division as well as the liquid biopsy lab that's led by Erica Carpenter, have been key collaborators on this work, and these are our funding sources. I'll stop there. Thank you so much.
Well, Dr. Bagley, thank you so much for that very, very interesting presentation. Dr. Attrell will now move on to the questions that we've received from our participants.
Thank you, Susie. Appreciate it. And thank you, Dr. Bagley. That was an excellent talk. We have a few questions here. Just start with, how is liquid biopsy being utilized or thought about in brain metastases? We talked about gliomas and glioblastoma quite a bit. What do you see as sort of the future in terms of brain metastases?
Yeah, that's a great question. I wish I had time to cover it. So in brain metastases, one of the key observations that's emerged in recent years is that the molecular profile of a brain metastasis actually may be very different than the primary tumor in diseases like lung cancer or breast cancer. So I think one of the most exciting and promising areas is doing a lumbar puncture on a patient with brain metastases to obtain ctDNA that's circulating in the spinal fluid and sequence that to understand the molecular profile of the brain metastasis, which again is different than the primary tumor. So we may be entering an era where we're actually doing one targeted therapy for the systemic disease and then changing to a different targeted therapy for what's going on in the central nervous system, especially since we're getting such an increasing number of drugs with better brain penetration, particularly for lung cancer and some other tumors.
Thank you for that. We have a question from Fred Padilla on that. You noted the difference between the mutations that were detected in tissue versus circulating DNA, and your thoughts on explaining that, and how do we differentiate the mutations that may be related to other things that are prognostic, like age and getting mutations in cells that are unrelated to the tumor?
Yeah, so that gets to this problem of clonal hematopoiesis. And, for a disease like glioblastoma, where most patients are going to be older, the median age is in the low 60s, a lot of our patients are going to have, clonal mutations in the hematopoietic cell line. So this is where I think, we need better bioinformatic pipelines from some of these companies that are doing this commercial sequencing to be able to filter out clonal hematopoiesis or CHIP. Right now, if you send a glioblastoma blood patient to one of these commercial entities and you get a report back, that you really have no confidence about whether that result is tumor derived or represents a mutation found in that patient's blood compartment. And until that issue is solved, I personally don't feel that we should be sending plasma samples on GBM patients on a clinical basis at this point in time.
Did you see in your analyses any correlation between cell-free DNA mutation load and the age of the patients, if you had patients in their 70s and 80s, since the age itself is prognostic?
It's a great question. As I showed you, there were only 20 patients. We did look at that and we didn't see any trend, but with 20 patients, the power to detect that so low that I think it's still an unanswered question.
Great. In the conclusion slide, you mentioned that you feel that CSF may be a better target for liquid biopsy than plasma. Based on the Sloan Kettering analysis, that their sensitivity was about 50%, which matched the large blood study in plasma. What sort of makes you feel that the CSF would be better?
Yeah, it's a really good question. I think that one key here is there's a difference between the number of patients who have a mutation detected in plasma versus the number of patients where that same mutation was detected in matched tissue. So that gets to how often can you find any mutation in the blood versus the concordance with tissue? Those are two different questions. I think, the data that I showed you that we generated in plasma from patients with glioblastoma had a 50% detection rate. And that the concordance with tissue was 0. So that's a really important point. Whereas in the Memorial Sloan Kettering data with CSF, the concordance with tissue was higher, around 50%.
Great. Has liquid biopsy been used to distinguish between true tumor progression and pseudoprogression, particularly in patients receiving immunotherapy?
Yeah, it's a really good question too. The best data for this comes from the melanoma space. There actually are a couple of really nice studies in melanoma where you can break patients down who are receiving immunotherapy into two groups, either those with a favorable cfDNA profile or those with an unfavorable profile. And a favorable profile just means that they didn't have anything detected in their plasma at baseline, or they had something detected and it went away on treatment with immunotherapy. And unfavorable was defined as either high levels at baseline that stayed the same or got worse on immunotherapy. And it turns out that if you have that favorable cfDNA profile and you have radiographic changes that look concerning for tumor progression, it's more likely to be pseudoprogression in that scenario. Whereas a patient with the unfavorable cfDNA profile, if that patient develops radiographic changes, very likely to be true tumor progression. So I think in the brain tumor space, it's still super early to comment on that. But with melanoma, I think it's becoming clear that there's a role there for cfDNA.
Thank you for answering that one. We have one from Joseph Frank who asks, can you address the use of focused ultrasound in differentiating radiation necrosis and recurrent tumor in GBM patients who may have elevated SUV on FDG PET? And what are your thoughts of using liquid biopsy and focused ultrasound together in lower grade gliomas where the blood-brain barrier is more intact?
So the second question, I think, is an easier one. And I think the answer to that is, I'm very excited about that possibility. I think that lower grade gliomas, as I mentioned, are really characterized by an intact blood-brain barrier. So focused ultrasound in that realm may be very helpful. And I'm just throwing out one example here. We just recently learned that in lower grade gliomas with IDH mutations, there's a very important prognostic marker, which is called homozygous deletion of CDKN2AB. And if that homozygous deletion is present in a patient with lower grade glioma, they're actually more likely to do a lot worse. And so they don't have that typical good prognosis. So that's the kind of thing where, if we can do FUS and liquid biopsy, maybe able to get that information non-invasively, at various points in the patient's treatment course. And I think that could be very helpful. Archal, I don't know if you can repeat the first part of that question. I think I didn't quite understand the main question there. FDG PET.
Sure. Yeah, I think for the subset of patients who have an elevated SUV on FDG PET, do you think that the use of focused ultrasound in differentiating radiation necrosis from recurrent tumor could have a use case?
Yeah, I'm not sure about that. I think we at least at Penn, we don't use FDG PET very often in our brain tumor patients because the entire brain is hypermetabolic and it's hard sometimes to tease out what you're actually seeing there. We tend to rely on MRI scans with perfusion and permeability metrics, and those tumors that have a lot of perfusion and permeability, probably those ones with high FDG uptake as well, tend to be the ones that have more of a disrupted blood-brain barrier. And whether applying focused ultrasound in that setting is the smarter way to go, or whether to really try to use it first in lower grade gliomas with an intact blood-brain barrier, I think is an open question.
Thank you for that's a great answer. This next question is, does the specific location of a brain tumor affect the likelihood that the liquid biopsy would be useful?
Yes. So at least with CSF ctDNA, we think that that's the case. There have been a couple of studies now, actually in primary brain tumor patients like glioblastoma that have shown this. It seems like common sense, but it was important to demonstrate this, that tumors that are in more intimate contact with CSF reservoir are more likely to shed DNA into the CSF. So, you know, if you've got a tumor that's abutting one of the ventricles, or another, you know, is in communication with the subarachnoid space, you may get better yield there. So I think that's a great question. And that's what I've seen so far. In plasma, we really don't know yet.
Well, Dr. Bagley and Dr. Atrol, I really want to thank you so much for organizing today's webinar, and this concludes it. If you were not able to address your question, or if you would like more information, please visit our website at fustfoundation.org or email us at info@fustfoundation.org. Again, thank you all for joining us today, and stay tuned to our newsletter and website for invitations to future webinars. And I hope everyone has a great day. Thank you so much.